Hello, everyone. My name is Walid Ariashi, and I'm the Director of Regional Anesthesia at Boston Children's Hospital and Assistant Professor at Harvard Medical School. Thank you for inviting me to talk at the World Day of Regional Anesthesia and Pain Medicine, and thank you to the organizers as well as the European Society and the partners who helped organize this meeting. I'm pretty excited today to talk to you about reimagining neuraxial anesthesia using ultrasonography. I have no financial disclosures. And the objectives for today are to cover why this matters, what is the relevant sonoanatomy of the spine in infants, and lastly, share some of the novel approaches that we're currently working on, but are also being worked on by other folks. So why does it matter? Well, because neuraxial anesthesia has not changed in over 135 years. Kohler in 1884 took cocaine and thought it was a good idea to inject it somewhere in the spine and see what happens. It made sense at the time that it would anesthetize that area. Later analysis actually turns out that it was probably epidural. August Baer in 1898 then tried it again with six patients, two of whom were children, where they injected cocaine. Unfortunately, they all had nausea and a headache. But before giving up, he decided that he was going to try it on him and his assistant. They tried it on each other. Unfortunately, for 4 days, they ended up with nausea, headache, and vomiting. However, thanks to the audacity of anesthesiologists, a few years later in 1906, spinal anesthesia really took off with the introduction of Procaine. Thousands of these were performed, many of which were children. So, how were the kids managed during the procedure? Interestingly, they were comforted with a nurse, and of course, they gave them cake during the procedure. So now, before we go on, I do want to address the elephant in the room, which is why are we talking about neuraxial blocks when peripheral blocks have grown so much over the years? While this is very true, this isn't a discussion of peripheral blocks versus neuraxial or central blocks. Rather, we should be thinking peripheral blocks and neuraxial in the right setting. There are special occasions where neuraxial blocks stand out as a better option compared to peripheral blocks and vice versa. But for neuraxial, it can be advantageous in several ways. One example is when you have a very large distribution area that you need to cover, whether it's dermatomes, sclerotomes, or osteotomes, especially in the chest and abdomen area. For example, a paravertebral block for the chest will cover only a few dermatomes and only one side compared to an epidural. Another key thing to note is how dense you want the block. Direct neuraxial will generally have a much denser block than any peripheral block, depending on the concentration that you use. That's not to say that you can't do it with a peripheral block like a paravertebral for a specific dermatome band, but it will certainly not be as dense as a true neuraxial. Probably the most important distinguishing factor is whether you have somatic and visceral coverage, or just somatic. In other words, both the skin and internal organ cessation, or just the skin. And a lot of times for laparotomies or thoracotomies, not only do we have the skin sensation, the somatic pain, we also have to consider the visceral pain of the organs. Lastly, in pediatrics, we are often limited by dosing of local anesthetics. And if you have multiple sites, it would be difficult to run continuous infusions in a small weight child. So using a singular neuraxial catheter, which covers more dermatomal areas at a lower volume, is significantly advantageous. Sometimes it's the best option that you have. All right, now that we've covered neuraxial and why it's relevant and important still, let's start by talking about ultrasound at the 30,000-foot view. I want to draw an analogy. In medicine, for some reason, we do the same thing for a long time before we adopt technologies that have been in use for numerous years in other industries. Anyone still carry one of these? Yes, it's a pager, and it's a bit prehistoric at this point. This is a lot like using a messenger pigeon to communicate. Now we have FaceTime, and in the future, well, the future is interesting. Here's what it could look like. Does anyone know the Page the monkey? Well, this is one of Elon Musk's little pets. It has an implanted brain-machine interface with Bluetooth connection so that it can play ping pong. Yes, I know. In case you were wondering, this is the classic ping pong game, and the monkey's playing it simply by thinking about it, and actually does pretty well. In addition, the first two patients in the PRIME study, as it's been called when they enroll them, one patient in particular, Alex, has been able to play games and even do 3D renderings with CAD programming. And fun fact, this is how Neuralink fibers actually work. They work by ultrasound-based technology that transmits signals in that fashion. That's how they cracked the brain-machine interface to be able to use. Now, getting back to our subject matter, in medicine, we still use needles and blind guesswork, especially when it comes to neuraxial. Well, I'm going to challenge the audience here and ask why. Why do we do that when we have technology that can make the process better, especially in children? Ultrasound and children is a perfect match. We know that ultrasound is non-invasive, has no radiation, and is perfect in infants because of the lower ossification of their bones and the higher water content. This allows pristine sonographic images as the beam travels through their fluid-filled bodies. This is in contrast to adults where imaging is difficult due to the dense bony structures. Several studies have already shown this, and in fact, ultrasound is the main imaging modality used in infants to assess their spines for pathologies. So why wouldn't we use it for interventions, for neuraxial blocks? So how have people used ultrasound in children? There are two primary ways. First is by conducting pre-procedural scanning, and that is where you can scan the anatomy, measure, and then go ahead and mark your distances and approach and conduct the procedure right after. The second is when you use imaging in real time to guide your needle to the appropriate target location until the procedure is complete. In other words, you're seeing the needle the whole time. So how do these two techniques differ? Well, for the first, it's been shown to have some improvement over landmark technique on the order of 60 to 80% first pass success rate, meaning the pre-procedural scanning portion. And in the second, well, the second hasn't really been studied. Not to worry, I will unveil some cool new stuff that is coming out of our center to help with that. So we'll start with caudals before we get into deep. Naturally, one would ask, why bother with ultrasound, especially when you've done thousands of these with a landmark approach? Well, there's no problem with doing it with the landmark approach, except when there is a problem. Here's a case report of exactly why it can be extremely helpful. A peds anesthesiologist with 25 years of doing landmark caudals, so thousands of them, inadvertently punctured the dura and had a wet towel. What happened? It was a 7-year-old boy who was scheduled for a posterior urethral valve ablation and vesicostomy closure. A caudal was attempted with an angiocath, but when the needle was removed, the clear fluid returned briskly, and the procedure was aborted for inadvertent dural puncture. In the recovery room, the child was scanned with ultrasound and found to have a very low-lying conus. In fact, it was only 1 to 2 millimeters away from the sacrococcygeal ligament, whereas it should have ended near S2 or somewhere about 23 to 30 millimeters away. Could this have been prevented by ultrasound? Yes. Beyond that case, several studies have shown that using ultrasound guidance improves the first pass success rate by over 40%. Second, there's shorter needling time, albeit overall procedure time may be a little longer. But even this is debatable given the skill level of the regionalists with sonography. Lastly, you can demonstrate the spread and you can even detect if there's a dysraphism like a tethered cord or a low-lying conus that you may not have known. This is the anatomy of the sacrum. This is the lateral crest, the sacral foramina, the median crest, coccyx, sacral cornu, and the sacral hiatus. We place the ultrasound either below the sacral cornu and scan cephalad or above the sacral cornu and scanning caudad until you find the appropriate location. This is the anatomy overlaid on the skin. Here, the probe is placed caudad and then translated cephalad, just like this. The dynamic scanning is to get the sonographic picture seen here. This is the sacrococcygeal ligament in green, the sacral cornu in red, and the sacrum or sacral bone in white. This view is also known as the frog eye view because it looks like a frog's eyes. Another way we view the anatomy is in the sagittal plane. You basically turn the probe about 90 degrees to get to the long axis, and then slide cephalad. This sagittal plane is what you end up with, this view. Notice again the following structures: the conus, or the thecal sac in teal, the filum terminale in yellow, the sacrococcygeal ligament in green, and the coccyx in purple. This is the needle trajectory you're going for. You see the orange needle moving past the sacrococcygeal ligament and into basically the caudal or epidural fat. This is a short clip of a single shot injection. Notice the cephalad spread to the left of your screen. It is highlighted here by the expansion of the black anechoic area, which is where the local anesthetic is being injected. This is an example of an epidural being threaded through a TUI. Focus your eyes at the tip of the TUI, highlighted in yellow. One more time. And there it is. This is a cross-sectional view of the spinal cord at the lumbar level, showing an epidural depression from spread of local anesthetic. Notice how it peels away from the ligamentum flavum. One more time. Now we will shift gears a little bit and talk about spinal anesthesia. All of the techniques described in those original manuscripts in the 1800s are still being used today. Here's an interesting educational video from the 1940s. I'm going to play it, but skip through some of it just to give you key highlights. Of course, there's some mandatory text.
Diagram of a lateral view of the spinal column, showing the spinal canal and subarachnoid space containing cerebrospinal fluid.
So we go over the anatomy.
And the spinal cord. The spinal cord ends in European adults at the lower part.
And we talk about where the conus ends.
In the nerve roots.
Then we talk about the technique, which is what we're focused on here.
And bends well forward. Then you can most easily correct. For this reason, in between, the spaces between the spines are increased. This allows more room for the needle, which is introduced vertically to the surface of the skin. Most frequent meningitis is with of Lysol in spirit. Jones's with the special malleable
Eagles,
which is the rigid on either side of the interspinous ligament.
local injection, and then advancement. No different than how we do it.
One side, on the side of the spinal canal.
And how to adjust. Again, it has not changed for many, many years. These landmark techniques are fraught with several issues. It's a small target area, especially in children, and thus very difficult to hold the needle in the correct position, especially if the baby is crying and moving around. Christiani showed that the first pass success rate was only 64%. Some centers even reported less than 45%. Now, of course, this depends on the center, the volume, the experience of the provider, and so on. Yes, that is all true. But I don't know about you, but most of us would not settle for that type of success rate. 45, 64%, even if you said 85%. Most of us would not settle for that, and I'll explain why. Here's another problem we run into, though, something we call a dry tap. Is it truly a dry tap in the sense that the CSF pressure is too low to flow out of the needle, or is it something else? Well, we actually have shown that the needle can be in the correct anatomic location, but it may be that the needle has only tented the dura and not actually punctured through it. Or two, the CSF pressure and volume is truly low. Or three, there's so much scar tissue from prior manipulations which may impede flow. With ultrasound, there are many ways around this by injecting saline, or what we call a saline myelogram, looking for dural distension as opposed to dural compression. If it's dural compression, then it's epidural. If it's dural distension, then it's intrathecal. Now, getting back to the original statement I made is that most of us would not settle for a failure rate that high. We cannot just rely on 60% success rate. In other words, a 40% failure rate. I mean, we want to go to 100% success rate. Does that sound crazy? No, I argue that it's not crazy. It's not lofty. Let me challenge the audience with this question. If you do think that that is crazy to go to 100%, would you be okay with a 60% first pass success rate with intubation? No way. Most of us will shoot for 100% every time. This is no different. We can raise the bar of excellence and say that we want to go to 100% success rate. Now, before we dive into the innovation, let's review some of the positioning anatomy. As mentioned earlier, the probe can be placed in a transverse or cross-sectional view, as seen on the bottom, or the longitudinal view or sagittal view, as seen on the top pane. The lateral approach is one where your patient is positioned in the lateral position facing you with your dominant hand on top. The reason to have it this way is because you have better ergonomics. The other position is to go prone. This is also even better in terms of ergonomics, and you can still round out the back and open the interspinous space by putting a bump underneath the belly. Now, let's dive into the anatomy a bit more. This is the spine and the short axis. We can look at the spine with ultrasound in this orientation by placing the probe directly over the spine in an axial cross-sectional position. The image that appears is as seen here. Now, this is a very high fidelity image. You can see the posterior aspect of the body is closest to the probe, and thus on the top of the screen and the anterior part is further away at the bottom of the screen. The probe is then moved in between the spinous processes so that you're in the interspinous space. Here you can see the paraspinous muscles, the transverse process, the dura, the CSF in black is labeled here as SA for subarachnoid space, and NR for the nerve roots. One more time. This is posterior, closest to the top, anterior, further away from the ultrasound probe. You have the paraspinal muscles over here. You have the dura. You have the subarachnoid space. This is the full dura in circular. And this is subarachnoid space here, here, here. And these are the nerve roots right over here. Again, this is the transverse process, or what we call sometimes a lamina. This is a sagittal or longitudinal view of the spine, placed in a cephalocaudal direction, with the head towards the left of the screen and the feet towards the right. Here you can see the spine. I'll start by pointing out the skin is closest to the probe and posterior. Anterior, as well as the vertebral bodies labeled here, are further away from the screen. And you can clearly see here the conus circulated. This is the subarachnoid space, which is the anechoic space. These are the nerve roots coming out, or the cauda equina, and this is the subarachnoid space. You can even see the central canal going through the spinal cord right here with the arrows. All right, enough of that. Let's go ahead and show you how this can actually be done. In the lateral position, you can see them this way. And usually you want to ensure you have proper ergonomics. You place the back away from you and you pull the ultrasound towards you. And it gives you a direct line of vision with your eyes, hands, needle, and everything else. In this particular example, I did use local anesthetic. It's a pressurized delivery system where you can press it, and using CO2, it pushes the local anesthetic through the skin without a needle. It really helps with crying and movement of the baby. And this is a video showing actually in-plane needling as the needle enters into the dura. You can see the needle here indicated by yellow. And you can see the dura here distending as soon as injectate is delivered. Again, showing you the needle, the dura, and the distension. Again, we have a few more images of it. Here's yet another video demonstrating the same thing. And here you can see the local anesthetic being injected and creating a swirl with the nerve roots. See the swirl there. Interestingly, the same concept can be applied for epidurals. Why not? You can advance a 2E needle into the space. Right here, you can see the same structure. This is the dura right here. And this is the needle entering through paramedian approach and into the interspine through the interspinous ligaments and right into the epidural space. Here's a video. And it sort of cuts out once the needle gets into the epidural space, but you can see it right there. And you can see the pulsations of the dura right here. All right. So how well does this technique work with spinals? Well, I'm going to give you a little bit of a preview. It's still early. This data is not published yet, but this is from our institution since we've started doing them and teaching them, and of course, sharing and collecting data. There were 196 total spinals. We specifically looked at those performed by attendings only. We found that the first pass success rate with Landmark to be about 60%, which is consistent with the literature. But with ultrasound, we went to 100% success rate. That's about a 40% difference, pretty sizable. Additionally, we also looked at the conversion of general anesthesia, and we found that with Landmark technique, we had about a 12% conversion rate from spinal attempt to general anesthesia, whereas with the ultrasound group, there were no conversions. What we can say is that ultrasound guidance for infant spinal anesthesia may be a viable technique, especially in real time, to improve the overall first pass success rate and as a rescue technique for difficult or failed landmark-based approaches. So there are obviously some challenges in doing this technique. First, it is an educational desert out there when it comes to these approaches. There really isn't any great resources for learning these techniques. There also isn't any great videos. There aren't any great simulation or mannequins or devices that you can use to help with this. Second, these methods have a very steep learning curve that require good spatial imagination. You first have to be really good with ultrasound guided blocks in plane. Then you have to be really good with working with very small anatomy or small children. You also, lastly, have to be able to do it all with movement. And that is not an easy feat to do. So very steep learning curve. And this is just a demonstration of what the target looks like when it's moving. And so, yeah, it's a challenge. And there are lots of challenges. But I think there's a lot of work to be done in this space. And it has an interesting future. For one, it will be critical to develop educational models, as I said. Another is to make sure that this information can be disseminated widely in a very useful, teachable format. Second, most importantly, we need to conduct controlled trials to compare this versus other techniques and where it would best fit. Would it be great as just a rescue technique? Would it be great as a primary technique? Does it make a difference whether you sedate the patient or not? These are all excellent questions and ones that we need to study in the future. With that, I will conclude with the fact that every field of medicine needs innovation. Today, as a humble kid tinkering with various toys like ultrasound, I hope I was able to share a little spark of fire with you so that you can begin your own journey. For anyone who's interested in joining me on this journey, please reach out directly and I can share and connect you with a community we are building in the field of pediatric regional anesthesia and point of care ultrasonography. We're also contribute to quite a few organizations and we're all connected as one large community. But let's get together and really push this forward. Thank you so much for your time and thank you for sharing your expertise and questions, and I look forward to connecting with you all. These are the references.